Yeah, so the question was, in PLS, what research has been done to look at the effects of bladder and bowel involvement? This is an interesting question. We actually published a paper looking at PLS and comparing it to a condition called HSP, which is another condition where patients get a lot of spasticity in their legs. What we found was that in PLS, you can get bladder and bowel symptoms, but not to the same degree as these other conditions. So at times you can get an overactive bladder. It's in a way a spastic bladder. So in PLS, the underlying physical complaint is spasticity. Difficulty with mobilizing, a very stiff and spastic gait. But that spasticity is not only just limited to the limbs, it can involve the bladder, but it's not very frequent. It may occur in about 15 to 20% of patients. In terms of research, I mean, no one's looked at it in great detail, but suffice to say that we do know that it does occur, and if patients do have a spastic bladder, there are medications you can try. There are medications you can try and reduce the irritability of the bladder muscles, and that may then help patients with their symptoms. So again, it comes under more supportive treatments, but it is something you can discuss with a general practitioner. It is something you can discuss with a urologist if you need to. Generally with bladder symptoms, a referral to a urologist is important because they can have a look and see how the bladder relaxes, how the bladder fills, and how it empties. And that's how you try and diagnose some of these problems.
Hello, thanks very much for your talk. I just wanted to ask what preliminary work has been done on Triomec that means that neurologists think that it shows some promise.
Sure.
And also, sorry, the second part to that question is current study that's going to be done, is that going to be a phase 2 study, and is there a placebo arm?
So the question was asking about Triomec, whether there's been any initial studies done and whether the study that's going to be undertaken is going to be a phase 2. I don't know a lot about the preliminary work, but I think there has been some initial studies done that suggest perhaps the retroviral treatment, especially in mice, may help reverse some of the symptoms. A lot of the work is still done on animal models. And in terms of the clinical trial in humans, yes, it is a phase 2 study, although I don't know whether there's going to be a placebo arm as such. Generally in ALS, the treatments and the trials favour enrolling patients as opposed to placebo. So normally in a scientific study, it's 1-for-1. You want to try and have one patient with the disease and one placebo. But in ALS, it's usually 2 or 3 ALS and 1 placebo, because I think we're all aware that generally it is a condition where people want to have something done and they don't just want to get the placebo. So that is something you can discuss with the neurologist. As I said, there are 3 centres in New South Wales where it will be rolling out, and I suspect probably before the end of the year. And there are also some centres in Victoria as well where it will be undertaken.
Hi, Dr. Neil.
Hello, how are you?
Good, thanks. My question is in regards to rizal. I understand it's supposed to slow the progress and add 2 to 3 months of extended life. Are there any numbers or statistics kept of patients dying with a diseased liver? In the final stages, the final stage of MND, the patient has a poor quality of life. And do the 2 to 3 months really matter? So in regards to this, why take rizal?
Sure. So the question is about riluzole and how riluzole has been shown to improve survival by 2 to 3 months. I did have a slide on that. I didn't put it on here, and I'll come back to that later. And then the question was, you know, is it worthwhile taking riluzole? Does it really make a significant improvement if it's only 2 to 3 months? And what about the potential toxicity of riluzole in terms of liver changes or liver damages? So with riluzole, it is usually taken once, twice a day. We do advise patients who go on it to have their liver function studies checked by their general practitioner at least every month for the first 3 months or so. Thereafter, they can reduce it to every 2 months and then every 3 months. You can see an increase in the liver function studies, 5-fold, maybe 10-fold, generally not to a point that we get too excited about. I've never seen anyone who's died from liver complications with riluzole. And I've probably seen maybe 150 MND patients now in the last 3 years. A few of them have not tolerated riluzole because of, you know, gastrointestinal side effects, but generally I find it's tolerated pretty well. And then we come to this important point of, well, look, if it really prolongs survival by 2 to 3 months, is it worthwhile taking? I would look at it in a different way. I would say that if we start riluzole fairly early on, and this is in respect to the paper that I published, so I only put one slide up there of my paper where I showed that there were changes in the cortical hyperexcitability. I showed that things had improved. I would say that if you can prolong the survival early on in the disease process, then that's important, right? Because when I see patients early and I start them on riluzole, or whoever starts them on riluzole, if you can keep them stable at that stage for 2 to 3 months, that's important, right? Because generally we're seeing patients early on, and that 2 to 3 month figure is really early on in the disease process. It's not saying that people will live for 2 to 3 months at the end of the disease. I mean, obviously they do, but the real benefit of riluzole is early. So if patients, to put it into a clinical example, if patients come to me with weakness of one right leg and one right arm, and they're having difficulty getting around, they're having difficulty using cutlery, but they're still functioning pretty well. If we start them on riluzole, potentially, as an example, we might be able to delay the left side getting involved by 3 months. So there, I think it's important. It's important because you're starting the disease early, you're starting the treatment early, and so then you're getting a measurable improvement. So that's how I would look at it. And whilst these studies have shown that it's helpful by 2 to 3 months, in some patients it could be more. It could be more. So I would say from our research that we've done looking at this, that it is an important tablet to start. Usually I would start it within the first 2 to 3 months. As you know, there is a delay in the diagnosis. We've got to get it right. I wouldn't start someone on it straight away. But once we do start it, I think it's important because you're going to try and stabilize them early on. Eventually, the disease will progress and get worse, and we all know that. But the main thing is to keep them well when they first come and see us, when they're still getting around and doing things.
Ellen?
Hi, my question is in regards to the, I think it's the phenotypes, where you had the little circles of the thing. In regards to the genetic strain, specifically the C9orf72 gene, does that progress differently from patient to patient, or is it, does the C9, does that gene fall into one of those categories in particular?
Sure.
Does that make sense?
So the question is relating to the MND phenotypes. This was in the slide where we had the classical ALS and we had the upper and lower motor neuron variants on either side, the PMA, the PLS, and asking specifically in terms of the C9orf gene, which is now the most common gene that's implicated, where does that fit in terms of that spectrum of those different circles? And does it progress differently? So C9orf, as you all know, it's the most common gene. It generally tends to present with fairly classical MND. So really, it follows the numbers. So about 80% will go on to developing classical ALS. Again, 10% will become the PMAs, 10% may become the PLS. There are certain features of the C9orf gene which are interesting to note. So patients who have the C9orf gene tend to have more mood symptoms. They can have quite bad dreams. They can have some paranoid ideation, some psychotic type symptoms. So those are clues that this could be C9orf mediated. Furthermore, there is a greater proportion of C9orf patients who have the ALS FTD, not the 3 circles at the top, but the one down the bottom. And really, this is the study that I'm still doing at Westmead, and it's funding that's been supported by the MND Research Association, where I'm following up patients who are carriers of the C9orf gene, following them every 6 months to see how things change. But generally, it's fairly typical in terms of how it presents, but it's the cognitive changes, the mood changes, and that overlap with the FTD that differentiate it between the other types.
Thank you for your time. In regards to the question that was just asked recently about riluzole, one of the slides that you had showed a 39% effectiveness for the bulbar cases. Is that correct?
I think that was looking at the last slide and showing that it's almost as effective as riluzole in terms of the multidisciplinary MND clinics. Right. So,
yeah. You mentioned that riluzole tackles the glutamate hormone, or the hormone that contains glutamate. Are there any other contributing factors that cause the production of excess glutamate hormone.
Sure. So the question was about riluzole, and the first part of the question, I should repeat that, it was whether it is effective in 39% of patients. And I think that 39% is to say that we can improve things by about 39%. It's fairly arbitrary, but it's similar to the improvement in survival you would see with the clinic setting. The second part of the question was, how it works in terms of blocking the glutamate, and is the glutamate coming from a particular area in the brain. There have been some studies looking at this, and some of the studies seem to suggest that as opposed to the motor neurons themselves, which are affected with motor neurone disease, the supporting cells such as astrocytes, right? They're the cells that form the matrix where the motor neurons cells live. These cells seem to have a defect in a transporter whereby they're not mopping up excess glutamate. Now, we need glutamate to be able to send signals in the brain, right? So the moment we want to do something, there's a complex pathway, and the glutamate to a certain degree tells us, okay, start moving now, start doing things, start walking, start talking. But if you're releasing all this glutamate and you're not then reabsorbing it, then you're getting excess glutamate. So the riluzole tends to block it, which seems to suggest, yes, there is an excess, and maybe it's because of this abnormal reabsorption. The cells should be reabsorbing it more, but they're not able to. Our magnetic test, those little curves that we looked at, they're again measuring excess glutamate activity. So there is something going on with glutamate, but like that pathophysiology slide I put up where, I had this nice picture of a motor neuron, lots of different, arrows and different things going on, I think it's one part of the puzzle. I think, and this comes back to the question we were asking about the effectiveness of riluzole. I think riluzole ties in and helps to counteract one part of the dysfunction in motor neuron disease, but there's more. There's more to it. That's why we're only seeing a subtle and a modest improvement in quality of life. Until we find out what the other pieces are in the jigsaw, we're not really going to get that cure, or we're not really going to get that disease-modifying drug. So the riluzole, to a certain degree, tends to help by blocking the excess glutamate, but there's more than just glutamate. And therein lies the challenge. And this virus, this endovirus, maybe that's another part of the puzzle. And maybe this, this TrueMig, this viral treatment in combination with riluzole may give us 6, 9, 12 months. We don't know. But it's an exciting time. It'll be good to see what comes out of these trials.
Thank you for your talk. My question is, with riluzole, is there a time where the patient actually stops taking it, or do you keep on taking it for whatever time? Sure.
So the question was, with the riluzole, is there ever a point where you stop the treatment, or is it really a lifelong, treatment? Generally with riluzole, if patients are tolerating it very well, my advice would be to keep taking it. It's not really a drug that's going to cause a significant degree of side effects. As I said, there are some patients who don't tolerate it, and if that's the case, that's fine, we can stop it. But if they tolerate it, they don't mind taking it, then I would just keep taking it. And I think the effect with the riluzole is fairly early on in the piece. So later on, if it becomes difficult for them to swallow a tablet, then that's fine. We have to be pragmatic with it, but generally it becomes a lifelong treatment.
With the TriMec, do you know when the trial will start, as we've been waiting probably since about May or June?
Sure. So the question's about the TriMec and when the study will start. Because it's a multi-centre trial across 5 different sites, there are delays with ethics, and I think unfortunately, this is what we face in clinical medicine. Obviously, as an audience, we want to try and start the treatment as soon as we can. But all the different hospitals that are involved have to sign off. Everyone has to be aware of how the study is going to be run, how patients are going to be followed up. And it comes back to this important point that in medicine, we should first do no harm. So whilst we want to try and expedite treatment, get it out to patients as early as we can, we need to make sure, one, that we've got an appropriate system in place to run the trial, to make sure that patients don't slip through the gaps, to make sure that if patients have any side effects, they're treated on promptly, and to really ensure that the study is going to be done appropriately so we can then publish these results. Because at the end of the day, yes, we wanted to help people in this room or in New South Wales or Victoria, But then we want to be able to publish the results and have this accepted in Germany, in America, and the rest of the world. And to facilitate all of that, it has to be done in a rigorous manner, and therein lies the delay. You know, you've got ethics, you've got committees, you've got to wait for everything to get signed off, because you can't just give a medication, because if you cause harm, then the study is a write-off. And the moment that something goes wrong, then everyone else gets affected as well. But I'm hopeful that the study should be underway towards the end of this year, although we haven't got any firm dates. So really it's a matter of being in contact with your clinician and just waiting to see how things eventuate. But usually once the trial is up and enrolling, like I know at Westmead, I've got a database of people to start calling, and we'll chase people up, and we've got nurses to help do that as well.
Thank you. Does ALS affect or impact on bladder or like other bowel functions or hearing, eyesight, anything like that?
Sure. So the question was, does ALS affect any other systems in the body like bladder, bowel, hearing and visual symptoms? So generally motor neuron disease is a disease of the motor neurons, right? So you remember that slide where I had the brain and then the red lines going all the way down to the spinal cord? It's generally limited to that area. The dementia is different, right? That's a different issue altogether. But in that area, the bladder and bowel can be affected. And I think similar to the first question that I answered, you can get some bladder symptoms. But in terms of visual hearing symptoms, not usually. Because this really is a disease of the motor neurons. Everything else in the brain seems to be working fine. Everyone that gets this, generally are doing very well in their life. They've got nothing else going on. But there's just this failure of the motor neurons, and that's the frustrating part of it. Because if we could address that, then their vision is fine, their hearing is fine, their blood pressure, cholesterol, everything else is going well, bar this one problem with the motor neurons.
Last question, I think. Oh. Up the back.
Thanks, doctor. Is there a difference in the symptoms for Parkinson's compared to motor neuron disease?
So the question is there a difference in the symptoms between Parkinson's disease and motor neuron disease? Yes, Parkinson's disease is very different to motor neuron disease. It's mediated by a lack of a hormone called dopamine, and patients present with tremor and reduced facial expression and a slow shuffling gait. But in motor neuron disease, it's quite distinct. There's a degeneration of the motor neurons. Whilst there have been some very rare associations between the two, really they're two different disorders. So in neurology, there are a number of different neurodegenerative syndromes. One is Parkinson's, another is, say, Alzheimer's dementia, and then you've got motor neuron disease and FTD. And they're all different. They're all distinct. Pathologically, when you look at the brain in autopsy, or even when you're examining them clinically, they are all very different. So if that's the last question, I'll probably leave it at that. And I said I'm always very keen for healthy volunteers and supporters. So I'm keen to see people at lunchtime if they want to try and spend some time at research at Westmead. Thank you.